السلام عليكم ورحمة الله حياكم الله جميعا. It's a pleasure actually to be with you all, and we will just actually really go through such a thing because Gbs been for a long time. Like I would say, it's not an area of debate, but it has been always like an area of gaps since the start. So let's actually go and have a quick. First of all, we start with some questions. Do we need to screen women?
Yes.
صوت واضح؟
Yes, we need to screen one.
صوتي واضح؟
أيوة.
واضح.
Okay, so the question number one is, do we need to screen pregnant women? The second question is, are we screening pregnant women?
Yes.
And what kind of screening are we doing? And number three, what are the challenges, if there are any? And number four, can a woman who is negatively screened become positive? Especially putting in mind that screening is usually recommended between 35 and 37. So the last question is, who is screening these ladies? Is she being screened at family physician, at primary health care centers, or is she screened at the hospital she is referred to, and we will see what goes on. So Gbs stands for a group B streptococcus, or a Streptococcus agalactiae, and basically it's one of the bacteria that is colonized in some mothers, and usually this bacteria is passed through the baby through the vaginal birth canal when the baby is like born or during birth. The highest risk factor of Gbs disease in newborn is the presence of Gbs itself in the maternal genital tract during childbirth. So in other words, some women would have it, some women will not have it. And if the woman is colonized with the bacteria, then that is the risk when a baby can have it. If a baby is delivered by cesarean section, for example, a planned cesarean section, then there is no worry because the baby is not passing through the birth canal. A rough estimate is that one pregnant woman out of 4 will be having the Gbs colonization. What happens, why Gbs is important? Is it because the effect of Gbs on mothers? There is no effect on mothers. The mother has no problem if she has it herself. The problem is with the baby, with the newborn that is born with the Gbs. For example, a severe disease during the first week of life. I'm sure my colleague actually, Dr. May, will be talking more about the pediatric side, but we just go through it roughly. So it's the first week of life, sepsis, pneumonia, meningitis. Mortality rate varies, however, it is between 8% to 20%. And in case of survival, that's the problem with meningitis, neurologic sequelae, 15 to 30%, blindness, deafness, severe mental retardation, and cerebral palsy. Strong correlation with maternal Gbs colonization, so we know that this bacteria is related to mother's colonization and affecting infants aged more than 1 week. So this is the target, this is the time, because in the past we used to treat mothers during pregnancy to give them a course of antibiotic while they're pregnant. Of course, that's given up a long time ago. And the other thing is it might cause bacteremia, meningitis, and death. And finally, it's as we said, if they will survive with handicap. So what are the problems in Saudi Arabia? I mean, what is the issue or the key gaps in Saudi Arabia? We don't know exactly what is the prevalence in Saudi Arabia. However, studies are showing something between 10 to 45% with big variations from one area to another. There is no standardized national screening guidelines or universal pathway. Inconsistent risk-based approaches miss many of these colonized women, and the culture delay, which is usually 24 to 72 hours. And again, we don't know the resistance of the bud to reading ampicillin. Is it really working, or there is resistance to ampicillin? One of the things that I will just go through it quickly. Unfortunately, most of the hospitals, there is a big hassle with the culture. What happens is sometimes you send the culture, they tell you the culture is not mentioned as Gbs. When you put a Gbs, they say it gets rejected. The purpose was not mentioned clearly. Some people would do only vaginal swab, they don't do the vaginal rectal swab. Sometimes the swab is not available. Sometimes you send the culture and it takes forever. And sometimes it comes back and without sensitivity and so on. So a culture is always a problem. Again, the lady might have the culture done somewhere, and then she goes and delivers in another place. For us, for example, 60% of our ladies are unbooked when they come to deliver with us. So all these things, you know, if you put them together, are big challenges for screening mothers and be ready for the baby. The other thing is, what is the burden? Again, as we said, the prevalence is like between 10 to 44% colonization. However, the exact, you know, prevalence is like, these are scattered studies from here and there. Now, the burden of disease in some regions is like 4 in 1,000 live births, and in some diseases it's more, in some studies it's more or less. The mortality is up to 13% in some of these studies, and the antimicrobial resistance in some places it might reach up to 87%. So this is actually very important. I'm sure actually on the other end, our colleagues from neonatology will tell us more about, like, are they really facing such a resistance, or it is just only in the literature? Because usually we just use ampicillin in case of allergy to penicillin. Clindamycin is used, and of course it's not as effective as penicillin. So we don't have a national multi-center prevalence that can tell us exactly what is the burden of the disease. The current state, there is a risk-based approaches predominate, and which we are missing many colonized women, that's true. Inconsistent swab timing, sites, and methods across hospitals. No national policy or a standardized protocol or guideline, whether it's from the Saudi Commission for Specialties or MOH or anywhere. Some people would do, some people would not. And limited rapid testing, which is very important. No rapid testing in most of the hospitals, the so-called POCT. And again, variable awareness among healthcare professionals. I'm sure till now, some people think it is like, it's something trivial, it's something rare, it like never happens or rarely happens. And that's why, you know, these challenges, I think, would make our approach very hard unless actually we get them controlled. And of course, you know, screening is important, especially with the emerging vaccine. Hopefully, actually, we'll see it coming soon. It's in phase 3 now. So screening is very important and crucial, whether for the vaccination or actually for the pathway and so on. Many times, actually, we tell our colleagues, those who are coming with acidosis or with some neonatal complications and so on, I wish actually all of them get screened for the Gbs, because Gbs, it does exist and it does actually affect the outcome. And again, you know, something that can be prevented. We hope actually we get them screened, caught, and treated on time. Thank you.
Dr. Ahmed, thank you so much. You covered very well about the Group B streptococcal infection. What is the epidemiology? What is the current situation about Group B streptococcal infection in Saudi women, which is showing most of study showing we have a high prevalence or colonization rate in pregnant women. So GBS, again, it's a group B streptococcal bacterial which normally colonize the female genital tract. It can cause some maternal effect during pregnancy. Sometimes you ask for urine culture and they found the patient having group B streptococcal infection. You provide oral antibiotic, for example. Additionally, can cause fever, antepartum fever, for example, or chorioamnitis in severe cases. Recently, in the literature showing there is a strong correlation between preterm delivery, intrauterine fetal death, and even abortion during pregnancy and GBS colonization. In pediatric population, we know that it can cause starting from just fever, neonatal fever, which we have to suspect a group B streptococcal infection, can be skin and soft tissue infection, can be osteoarticular infection, severe cases having meningitis, and sometimes have a sequelae of meningitis. Mortality rate ranging from 5 to 11%. Most of Saudi data showing the mortality up to 5%. Other in Gulf regions showing it range between 7 to 10% to having mortality related to GBS infection. Additionally, with meningitis, up to 11% have severe neurological deficit. Some of them can having like a motor deficit, seizure disorder, baby shunt insertion, and they need frequent follow-up. And just imagine how is the outcome or the impact on the family member. The issue that we need to screen the pregnant women. That like in 1990 they started the CDC to implement culture screening, not culture screening, risk-based screening mainly for GBS infection. So women with the high risk for GBS, like having preterm labor, previous GBS, just will provide prophylaxis, no need for universal screening. However, they found that still we missed some cases, still not being as a high risk, but developed later on, the baby developed GBS infection and they developed severe even infection. So in 2002 changed the recommendation to be universal antepartum screening by American College of Obstetrician and Gynecologists, the CDC, American Academy of Pediatrics, all going now with universal screening with culture, or even some regions start to apply PCR at time of delivery just to have a positive, to know about the GBS situation at that time. Okay, so from pediatric point of view, I can say that it causes meningitis, it causes bacteremia, it's fine for everyone. But just to imagine how it can be this scenario. Here, the first case I would like to, all the real scenario during my career. The first one, I'm in Prince Sultan Military Medical City. I'm acting as a patient safety. So at the first time I received the incident as a sentinel event. I think everyone knows what is sentinel event. So this baby mother admitted with rupture of membrane, baby fetal pulse was fine, everything was okay. At 18 hours, because now it's a high risk because she has prolonged rupture of membrane, they start to give only 1 dose of antibiotic. So suddenly the midwife, they called there is no fetal pulse, unfortunately. So they developed intrauterine fetal death. So what happened? I tried just like when I received to look for the gaps, everything was fine. The fetal heart rate is okay. They start antibiotic based on the risk base. So where is the gaps? So I opened the find. I found that the culture, the mother from histopath found to have severe chorioamnitis and funicitis. They call it funicitis, and also with high vaginal swab and rectal swab positive for GBS from the placenta as well as the culture. So unfortunately, the mother, she lost the baby in the last trimester, or even for few hours before delivery, secondary to GBS. So the second case, this is during my residency, I published this case in King Fahd Medical City with the team. We have a newborn just discharged in the second day of life. He was in good situation. After 6 hours, he came back with fever, lethargy, poor feeding. Neonatal sepsis workup was done, and suddenly he developed like a berbera fulminans picture, necrosis everywhere in the body. So everyone think about meningococcal. So after that, it confirmed to be GBS infection. Mother was following at that time without any GBS screening was done for her, unfortunately. And after that, we take an action. We present the case in morbidity and mortality meeting. Everyone was concerning about GBS and start to make a screening for GBS. But unfortunately, the baby died after 48 hours, being hospitalized in ICU, started in inotropes, and he passed away from GBS infection. This is also like 2 or 3 years ago. I was consulted to see this patient. He's a 7 days old. He started to have 2 days of fever, lethargy. He went to primary health care. They give him like oral antibiotic, like a viral illness. Unfortunately, he came back in very bad situation, status epilepticus, seizure, found to have severe hydrocephalus empyema, and underwent surgical intervention, need VB shunt, admitted for 6 weeks for IV antibiotic, recurrent brain imaging, and at end he like a child with neurological deficit on VB shunt, and just imagine how is the family. So this is mainly the clinical aspect. This is maybe you have seen the complicated cases, but what about GBS bacteremia, for example? Any neonates with fever, we have to admit, give antibiotic. We have to give antibiotic for 10 to 14 days. So just imagine the impact on mother. He just delivered like 1 or 2 days ago, and now your baby is being hospitalized. He will receive the antibiotic. We are aware about CNS infection as well. So at least he need hospitalization ranging between 7 to 14 days. And the severe cases, for example, up to 6 weeks sometimes. So this is the impact. We didn't. Yeah, sometimes from gentamicin, we have to follow the hearing assessment for anyone with meningitis as well. So this is mainly the clinical, psychological impact on the mother. If she lost her baby, she developed severe disease later on. I would like also to highlight the value-based. If just we have a screening or point of care testing relating to GBS and the maternal knowledge about GBS, and ask the physician just to do GBS for me. And I was also, when I was pregnant like 10 years or 11 years ago, I asked the obstetrician, do for me GBS. He told me, you know GBS? I told him, yes, please do for me, because I am a pediatric infectious disease. Okay, I will do it for you. After that, really, they start to practice GBS screening. But as Dr. Ahmed mentioned, that we have sometimes the swab is not available. The clinic, we have 30 patients in the clinic, no time to take the swab. Who will do the swab? The midwife or the physician? I'm busy, please do the swab. Again, the culture issue, we need to wait at least 48 hours to have the culture. So all this can impact. The cost burden, just imagine if we have patient admitted for 7 days, hospitalized in general ward, how it will cost. كم تقريبا? How much? What do you think? اليوم بكم؟ 2000 مثلا، صح؟ يعني at least 20,000 to 60,000 for regular cases between 7 to 14. Yes. في الورك. Sometimes they need, and it's range between 20 to 60,000 cost of one case of simple infection. This case, I make just AI calculation per day with the intervention, with MRI, with VBC, with the cost. It cost 1 million real, more than 1 million real. Only one case of complicated GBS infection. So that's why just I would like to see what is the effect of GBS cases. Really, I'm reporting any woman he came with GBS infection and the incident report system to go for RCA to make an action plan. But unfortunately, with most of the physicians, they're going for the risk-based because of lack of screening. Most of them unbooked. Dr. Ahmed, he mentioned we have almost 30% of the cases unbooked. They came from the periphery as well as in our hospital. Most of cases unbooked. They came on time on labor with rupture of membrane. So what we can do, just follow the risk base. We don't have a rapid test to identify GBS. That's it. Thank you so much.